Good evening. I'm psychiatrist Jay Fawver, and welcome to Matters of the Mind. Matters of the Mind is a weekly mental health program where you get to choose the topic for discussion. So if you have any questions concerning mental health issues that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. That's Matters of the Mind at WFWA.org. And if you're able to do so during the program, you may also text or call me. So let's begin tonight's program with an email I recently received. Dear Dr. Fawver, how common is multiple personality disorder, and can it be treated? Multiple personality disorder is now known as dissociative identity disorder, DID, and it's a condition by which people not uncommonly will have difficulty under some kind of stress to flip into a different personality and often dissociate in such a way that they don't remember what's been going on around them when that happens. So with dissociative identity disorder, they dissociate or they lose track of time for a few seconds or a few minutes under stress, and then they go into a different personality. That's where dissociative identity disorder comes in. They go into a different personality. Now, why would they go into a different personality? It's basically a coping mechanism by which people learned as an early child to kind of get away and zone out from their particular trauma that they were enduring. It's not uncommon to see people who have been sexually abused, severely physically abused. What they do is they just zone out and they just are going into a different place during that time, and sometimes going into a different type of identity or personality will be something in which helps them cope. Now, if some people will go into a personality of strength, some people will go into a childlike personality. They go into different personalities, often based on the difficulty that they're experiencing. Now, in a stressful situation as an adult, the problem will be with dissociative identity disorder is people will inadvertently go into these different dissociative spells, and they might briefly flip into a different personality, forgetting that they did it. And it's often just from maybe their coworker speaking a little bit harsh with them, their spouse saying something derogatory to them, just something that hurts their feelings or something that's somewhat stressful for them will cause them to flip into these different personalities. So that's where it can be difficult to endure as an adult. It is treatable. Multiple personality disorder, dissociative identity disorder is treatable primarily with psychotherapy. The idea of psychotherapy is to help you cope with life circumstances in such a way that you don't need to dissociate or flip into these different personalities when you're under stress. Previously, years ago, hypnosis was a treatment of choice for that kind of condition. Now we're going to use different types of psychotherapies to help you deal with the different personalities. Sometimes medication can be used as a means of helping you with greater stress resilience. Stress resilience just means being able to put up with stuff better. And there are medications that can do that as well. Thanks for your email. Let's go to our next text. Hello, Pam. Welcome to Matters of the Mind. You had contacted us from Fort Wayne, and you want to know about inflammation. Hello, Dr. Fawver. In a previous episode, I heard you say that inflammation of the brain, I heard you allude to inflammation of the brain. What is this? Inflammation of the brain, Pam, is basically where you have the individual neurons that are getting basically flooded or marinated with inflammatory proteins. We have fancy names for these inflammatory proteins such as interleukin-6, tumor necrosis factor alpha. These are all inflammatory proteins that get released by our little cells that surround the neurons. Now, we have 80 billion neurons, and each of these individual neurons are surrounded by about 10 glial cells. Glial refers to glue in Latin, and glial cells hug the neurons, and they nourish the neurons. And there's about 10 per neuron, and they're kind of like a pit crew. If you look at an Indy car race and watch that, you'll see a pit crew of about 7 pit crew getting around the car in about 7 seconds. The pit crew can change 4 tires and pump in a full load of fuel, and off the car goes in about 7 seconds. Well, we have a similar pit crew around each of our individual neurons. If those little pit crew in the brain, which are called glial cells, if they get sick or they're not functioning properly, they release inflammatory proteins. Now, it's an interesting phenomenon because when they release inflammatory proteins, they will then cause greater toxicity to the neurons themselves, and the neurons don't act properly. And that's when people get depressed, they have bipolar disorder, they have conditions like Alzheimer's, dementia, all sorts of bad things can happen from inflammation of the brain. And it's interesting you asked that particular question about inflammation, Pam, because one of the treatments for inflammation of the brain can be a glycogen a glucagon-like peptide, glucagon-like peptide number 1 agonist, which is called a GLP-1. Medications like semaglutide, also known as Ozempic, Wegovy. These medications are used for diabetes, they're used for weight loss, but they're also used now for the possibility of helping people with mood conditions. They're being studied now for mood disorders and bipolar disorder. Opiate use disorders are very commonly addressed with this GLP-1. So the glucagon-like peptide number 1 agonists are the type of medications that can directly in the brain decrease inflammation. Now, they've got to be studied further to determine if there's going to be any long-term bad effects that can occur with these kind of medications used in these conditions. Some patients might notice they feel kind of emotionally blah. The biggest issue I see right now with GLP-1 agonists will be the muscle loss that people experience. When you take a medication like semaglutide, it can cause you to have significant muscle loss. So now I'm hearing a lot of nutritionists and endocrinologists who are prescribing the GLP-1 agonists. They're saying you really got to do resistance training. And I've been recommending that to many people I've seen over the years who are on these medications, because if you're having muscle loss, that's going to affect you in different ways, and you need to stay strong. So resistance training is very, very important for these people, but the decrease in inflammation of the brain is what's intriguing us as psychiatrists. Now, there's various other medications that can decrease inflammation of the brain, one of them being lithium, as well as various other medications. But inflammation of the brain is thought to be one of the sources, one of the causes of many mental health conditions. Thanks for your text. Let's go to our next caller. Hello, Tyler. Welcome to Matters of the Mind. Tyler, you want to know about lithium. How does it help with bipolar disorder? Well, it does decrease inflammation, but basically lithium is a salt. It's a salt on the periodic table that's similar to sodium. So the body looks at lithium and sodium in a similar manner, and that's how it's excreted. So if you have a higher sodium diet, if you're taking lithium as a prescription, your lithium level can decrease. If you all of a sudden restrict lithium in your if you all of a sudden restrict sodium in your diet, lithium levels can increase. Now, naturally, we don't have natural lithium in our bodies, so it's not a matter of checking a lithium level if you're not taking lithium, but if you are taking lithium, there's levels that typically are effective somewhere between a level of about 0.6 milliequivalents per liter up to no more than 1.2. As you get higher on the lithium dosage, you can have such side effects as shakiness, headache, diarrhea, some uncomfortable side effects as you go too high on the lithium dosage. But lithium is particularly effective for people with bipolar disorder type 1. These are people who experience at least 1 week of manic symptoms where they get themselves into trouble. And during these manic symptoms, they might notice they have a decreased need for sleep. They are talking really fast. They go from topic to topic to topic. They're very impulsive, and that's where they will do things and say things that they later regret doing and saying. So lithium can be very good at stabilizing the brain chemistry in that way. It has some other mechanisms for depression in the sense that it can decrease suicidal thinking. Low doses of lithium by means that we don't really understand. Low doses of lithium, even below the therapeutic threshold of lithium, can decrease suicidal thinking. And I've seen it very dramatically with my patients over the years. If you simply give somebody 150 milligrams of lithium and they have suicidal thoughts, with an antidepressant medication, it can be very effective in decreasing suicidality. So lithium as a medication is often used for bipolar 1 depression as well as mania, but it stabilizes the mood. It's particularly helpful for people who have distinctive episodes of highs or lows. So they don't have the mixture of highs and lows at the same time. And it's particularly effective for people who don't tend to have any more than about 4 highs or lows in a year. So they're not rapid cycling, and they're not exhibiting mixed features of bipolar disorder. Lithium is typically best dosed in a controlled release formulation, all at bedtime. The textbooks all talk about lithium being given in the immediate release formulation 3 times a day. Number one, many people can't remember 3 times a day to take any medication. But number 2, if you dose it all at bedtime, it helps with the sleep, but it also is safer on the body itself. So we prefer to dose lithium entirely at bedtime in a controlled release formulation. Thanks for your call. Let's go to our next caller. Hello, Ann. Welcome to Matters of the Mind. And you want to know, is it normal for your antidepressant medication to cause severe stomach pain and nausea? Not normal, Ann. I think it's probably related, number one, to probably an antidepressant effect that's affecting serotonin. So serotonin has 14 different receptors associated with it. A particular serotonin receptor is serotonin receptor number 3. And in the gut, about 90% of the body's serotonin is in the gut, and if you stimulate serotonin receptors type 3, that can cause you nausea all by itself. Now, stimulating serotonin receptor number 3 is the mechanism by which you're trying to block when you use a medication like Zofran, also known as ondansetron. So ondansetron is an anti-nausea medication frequently used by people who experience nausea, and Zofran is very inexpensive nowadays, but it's a specific serotonin type 3 blocker. And if you block serotonin type 3 receptors, you can decrease nausea. There's a particular antidepressant medication called mirtazapine or Remeron. It's been around since about 1995, and it, as a mechanism, will block serotonin 3 receptors as well. So if you have nausea related to an antidepressant medication that's increasing serotonin, number one, we're going to look at, well, how long's it been going on? Can we decrease the dosage because the nausea is related to the dosage? Can you take the medication with food? That often helps tremendously. So if you take the medication with food, especially peanut butter and eggs and avocados, if you take it with food, often that will relieve the nausea. Many times the nausea related to antidepressant medications will be short-lived. It's going to occur over the course of 2 or 3 weeks, and we kind of write it out during that time. You can use ondansetron, for instance, during that time if it's related to serotonin. And we'll look at how well it's working for you. Within 2 or 3 weeks, a medication that's affecting serotonin within 2 or 3 weeks should give you at least 20% benefit. Doesn't sound like much, but it's a very key predictor that it's going to give you long-term benefits. So a little bit of a benefit as soon as 2 or 3 weeks can be predictive that you're going to do well over the course of time. So if somebody's doing really well at 2 or 3 weeks on a medication that possibly is increasing serotonin, they're feeling better, but yet they have nausea, I'm wondering, number one, is the nausea decreasing with time? And number two, can we simply decrease the dosage, take it with food as a means of mitigating the nausea itself? So there's ways to get around it. There are other reasons why people can have nausea from an antidepressant. For instance, bupropion is a medication that's increasing norepinephrine and dopamine. Bupropion is also known as Wellbutrin, has nothing to do with serotonin, but it's a medication that can increase some nausea just by enhancing dopamine. It's the same kind of effect you'd get from a stimulant medication. If you increase dopamine, sometimes it can give you kind of a sickly feeling. That's why people, when they first try the nicotine cigarettes, can feel nauseated. It's the dopamine effect in the gut. So if it's related to dopamine, that's a whole different phenomenon. So we'll hear about dopamine increases causing nausea. We hear about that with bupropion. There's a nasal spray called Spravato that's used for depression. That will sometimes cause nausea, and that's thought to be due to the dopamine increase as well. The way you get around that is, once again, wait it out. Number two, decrease the dosage of whatever you're using. And number three, sometimes we'll give a little bit of a medication like promethazine, also known as compazine, prochlormethazine, long word there, also known as compazine, as a means of decreasing the nausea related to a medication that's increasing dopamine. So there's many different options there, but yeah, it's not normal for you to experience side effects, but if you do, we just sometimes have to work around it. Let's go to our next email question. Let's go to our text question from Rita. Rita, you have a question about antipsychotic medications. Why do the antipsychotic medications increase appetite and cause weight gain? Well, Rita, we have a lot of different antipsychotic medications that have come out over the past 30 years. And their side effects have primarily been that they will increase the appetite. It's thought that they're affecting serotonin 2C receptors, particular serotonin receptors, and in doing so, they can increase the appetite. To a limited degree, they have an antihistamine effect that'll increase the appetite, but it's thought that it might have something to do with the type of serotonin receptors they're affecting. Now, some of the medications won't affect appetite as much as others. Doesn't mean they're better. It just means that they aren't affecting those particular receptors. Now, a medication like like olanzapine, also known as Zyprexa, profoundly can increase the appetite. We've noticed that since it came out in 1996. And just in the past few years, we found that if you combine a medication with olanzapine called samidorphan, that's a formulation called Lybalvi. Lybalvi is olanzapine with samidorphan. With olanzapine and samidorphan in combination, using Lybalvi, that does not seem to increase the appetite and weight gain like we see with olanzapine by itself. So there's ways to get around that, but yeah, some of the medications that increase the appetite will give you the weight gain. It was noticed that early in these studies on these antipsychotic medications, it was noted that individuals who gained the most weight early on often had the best antipsychotic effect with schizophrenia. That sounds weird, but if you think about it, when you're experiencing psychosis and you're really ill with schizophrenia, you're going to be paranoid and you're going to be careful what you eat. You're not going to want to eat many times. You're going to think your food is poisoned. All these awful thoughts are coming to your mind and you're losing weight when you're psychotic, not uncommonly. Well, these people who lost a lot of weight when they're psychotic, as they improved dramatically, they actually gained a lot of weight. So the original olanzapine or Zyprexa trials showed the people who had the best antipsychotic effect for schizophrenia were indeed the ones who had the most weight gain. So it's kind of a yin and yang there, but we still don't like people to have the weight gain. So there are ways. It's not the weight gain that caused them to improve. It's just that that was an after effect of their improving overall. Now, many people use the so-called antipsychotic medications for bipolar disorder, mood stabilization, as well as schizophrenia, and sometimes for depression as well. We don't want to have a lot of these people experiencing weight gain. So we have a lot of ways to kind of get around that, and I think any medication that comes out over the next few years that's in that class of medications, which we would call antipsychotic medications, any medication that comes out probably is not going to have weight gain as a factor associated with it, because we need to get past that. Already people with schizophrenia, bipolar 1 disorder, already they have difficulty with type 2 diabetes, and that was noticed 100 years ago before these antipsychotic medications even come out. It was noted that people with conditions that we would now call schizophrenia and bipolar disorder, people would have higher blood sugars, and we didn't even have antipsychotic medications back then. So the stress of having schizophrenia and bipolar disorder causes increased cortisol. Increased cortisol makes you more likely to become insulin resistant, and that causes you to have higher blood sugars and eventually type 2 diabetes. So what we want to do is try to improve the overall symptoms without causing the blood sugar or the metabolic abnormalities. Thanks for your text. Let's go to our next caller. Hello, Tim. Welcome to Matters of the Mind. Tell me, you want to know what part of the brain is used when you're challenged or hurt, and how do you cope? It sounds like you're describing, Tim, a phenomenon where, okay, you're under a lot of stress, you've been offended, you're trying to cope with different circumstances. So what part of the brain are you using to try to help you through all that? Well, there's different parts of the brain that might help you with coping in general, Tim. Number one, you're going to rely on past experiences. Hippocampus over here on the side part of the brain, which is in the thumb part of the brain, the hippocampus is going to store past memories. And you're going to hopefully be able to remember how you coped with different things in the past. Secondly, there's a little part of the brain in here. Let's see, it's right above the corpus callosum, called the ventral medial prefrontal cortex. It's right in here. The ventral medial prefrontal cortex, medial meaning it's on the inside of the brain, ventral meaning it's on the lower part of the top part. But ventral medial prefrontal cortex allows you to think through your current life challenges and compare those current life challenges to your own personal values and your past experiences, grabbing some of those memories from the hippocampus. And it's going to compare how these particular challenges match up with your past coping abilities and your whole identity itself. So the ventral medial prefrontal cortex really fires up when you're trying to cope with a particular circumstance. And as you learn from any particular circumstance, as you are enduring really challenging experiences, your neurons become more fluffy. And when they become more fluffy, that's called neuroplasticity. So instead of, having maybe 30,000 branches on a neuron, you might have 50,000 branches. As they can become more fluffy, it actually causes you to have greater resilience. Resilience basically makes the neuron stronger. It's like shellacking the individual neuron branches. They grow in number. They get increased branching over the course of time, and it helps you learn from past experiences. So, as I often tell parents and grandparents, you don't want to protect your children from scary experiences, from new challenges, from situations in which they might fail, because they're learning from all those experiences. We have to allow children to experience challenges and especially help them learn to fail and learn how to actually recover from any kind of disappointments. So as we're allowing them to do that, we're enhancing the little branching in their brain in that particular middle part of the brain called the ventral medial prefrontal cortex. It allows you to cope better. Now, if you don't cope so well with life circumstances, based on functional MRIs they've done of that part of the brain, that part of the brain doesn't brighten up so much. So in other words, if you can't cope with an experience very well and you're feeling overwhelmed, this part of the brain here that should get fired up when you're going through a particular life challenge, it goes quiet. And you don't want that to happen. You want it to get fired up and actually make you stronger in the long run. So sometimes atheists like Friedrich Nietzsche was the linebacker for the Packers. Nietzsche was a philosopher, a German philosopher. He said, what doesn't kill us can make us stronger. And yeah, as I said, sometimes atheists can get it right, but what he's saying is if it doesn't actually physically kill you, a challenge that you're enduring can actually make you stronger and stronger and stronger. And that's dealing with life circumstances in a resilient manner. And the part of the brain that can do that is right there in the middle. And a lot of neurochemistry shows that can improve. Thanks for your call. Let's go to our next caller. Hello. Let's go to our next text. Hello, Pat. Welcome to Matters of the Mind. Pat, you're from Fort Wayne. You want to know, do allergies affect anxiety and other things like energy levels, bowel issues, headaches, and not feeling well all over? And are labs needed when taking divalprox delayed release? Two different questions there entirely. I'll start with the divalprox delayed release, also known as Depakote. You do need labs for the CBC and liver function test, as well as the blood level for Depakote. Depakote is a medication. It's known as valproate, and it's been around for decades, used for mood stabilization, used for anxiety and irritability in some cases, but it's a medication where you do need labs to make sure your liver and your bone marrow is still working well, and make sure you're not getting too much of it. Too much Depakote can cause you to have difficulty with balance and memory disturbances. Allergies in general. Allergies can cause you to have all sorts of mental health issues. So we've heard about this with some people with mold allergies, with allergies concerning pollens. They'll notice they'll have more irritability, more difficulty with depression, more difficulty with motivation. So sometimes giving people a non-sedating antihistamine medication, or several of them over the counter nowadays, but a non-sedating antihistamine medication can many times improve a person's mood if the mood disturbance is related to allergies. Now, by non-sedating, I mean a medication that's an antihistamine that does not cross the blood-brain barrier, predominantly. Benadryl or diphenhydramine is an antihistamine. It's been around for a long time. 50% of that gets into the brain. So 50% of it gets into the brain. As an antihistamine, if you block histamine in the brain, it makes you sleepy. So right now, my histamine's sky high because I'm awake. So if you block histamine, it makes you sleepy. So a way of helping somebody with sleep, especially younger people, will be to give them an antihistamine like diphenhydramine. It'll make them sleepy. However, older people, as they take a sedating antihistamine medication, older I mean by over 55 years old, if you take an antihistamine medication like diphenhydramine, it can make you tired and sleepy all the way up to noon the next day. And driving tests have shown that older people who take diphenhydramine or Benadryl at nighttime for sleep, they might not notice they're sleepy in the morning, but their driving test will be impaired up until noon the next day. Don't want to do that in general. A non-sedating antihistamine medication is one that has minimal crossing over into the brain itself, doesn't cross the blood-brain barrier, and that inevitably for many people can decrease a lot of the difficulties with the allergy effects people can experience. Thanks for your call. Let's go to our next caller. Hello, Tom. Welcome to Matters of the Mind. Tom, you had another question about brain inflammation and iron toxicity. Can that potentially lead to dementia or Parkinson's? Iron toxicity can do a lot of bad things neurologically, so you don't want to have too much iron. Too little iron can often be measured not only by your iron profile, looking at your red blood cells and the amount of iron in your blood, but you also look at the storage protein called ferritin. Ferritin should ideally be above 35, 55 as a number. If the ferritin level gets too low, that can be problematic. But if you have iron toxicity, not uncommonly people can indeed have neurological effects. Iron is not directly associated with inflammation. Inflammation is a different phenomenon, but inflammation can indeed be associated with the possibility of neurodegenerative conditions like Parkinson's and dementia. As a matter of fact, as I mentioned before, a GLP-1 agonist is typically going to be considered for somebody who has early stages of dementia in a lot of cases. It'll be interesting to see how that pans out. But right now there's discussion about GLP-1 agonists being used to decrease the inflammation that's thought to be related to neurodegeneration, as we might see with Alzheimer's dementia. Parkinson's disease is a phenomenon basically where the middle part of the brain, it's called the substantia nigra, right down here. The substantia nigra, substantia meaning body, nigra being dark, it's a dark body. It decreases in its volume by as much as 50 to 70%, and that's where dopamine arises. So as dopamine is decreasing, you'll have muscle movement disturbances. Why does that occur? Well, a lot of different theories behind that, but inflammation might be part of it. Thanks for your call. Unfortunately, I'm out of time for this evening. If you have any questions that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. I'm psychiatrist Jay Fawver, and you've been watching Matters of the Mind on PBS. God willing and PBS willing, I'll be back again next week. Thanks for watching. Good night.
The preceding program on PBS Fort Wayne is made possible in part by
Cameron Psychiatry, providing counseling and care for those that may struggle with emotional and behavioral challenges. More information available at CameronHealth.com.